engaging with your practice population sometimes can feel like a daunting prospect, and particularly when you're doing it from a network perspective, there's so many different options available compared to when you're doing it from a practice or from a network perspective. In this episode, Andy and I are going to talk about our experiences of engaging with practice populations, what we're currently doing, what we would like to do, and what is possible by yourself with just a little bit of time, a little bit of investment potentially, and basically how you can hopefully engage better with your patient population as a PCN network. Let's take in hand to your primary care and learning. Hey GP learners, and thank you for joining back for our session where we're talking about PCN engagement with patients. So this is the third in our 4-series set, and next time we're going to be talking about engaging with practice and network staff in particular. And just before we get cracking, as you can tell, Andy and I are both in the same room. That's just because of recording stuff, but we're LFT negative, both vaccinated, and as you can see, wearing masks just to protect us with a ventilated room and things as well, because we're aware Omicron is slowly and surely, well, rapidly growing and stuff.
As we record.
We are. But yes.
We're doing that.
And like I said, we're going to be talking about engagement with patients in particular from a network perspective. And there are definitely some of these lessons that can be used from a practice perspective, I think. And we're going to talk about basically what you need to know, hopefully.
I think so, yeah. I mean, for the structure for today, we're going to just talk about patient engagement a little bit in general, place them on our stakeholder grid, which we'll explain about in a second. We'll talk about actually what my experience of patient engagement has been so far in Bulwell and Top Valley Primary Care Network. I'm a GP in Nottingham and a primary care network clinical director, as is Gandhi. And I think we'll talk a little bit about...
For a
different network, yes. Gandhi will talk about his experiences in his area. We'll try and apply a bit of framework to a discussion around patient engagement that you guys can apply as you map and plan your patient engagement plans within your primary care network or practices or organisation, and hopefully we'll leave with a better idea of what we're going to do next year for patient engagement.
And if you do have comments on about what we're talking about, definitely leave it down in the show notes, but in the comments below. Appreciate this is a pre-recorded one, so you can't join us live like we'd normally like to, partly because we're doing this over the Christmas break and stuff. But definitely keen to hear your comments and also your experiences, because I'm sure there are people doing some potentially better things than we are, to be honest, and definitely like to hear about it and share it as well. So we may do a second session afterwards. But let's get cracking with our matrix and stuff. So I'm going to bring it on screen for you, Andy, and there you go.
Yeah, so this is part of a series. So look back at previous videos when we've looked at engagement with other areas of the government and NHS. These are green. And other areas of community engagement with community organisations. We had some great conversations around that and placed them on the grid. And the grid's looking really, really busy with all of these bodies and organisations there. So let's remove them a little bit and just recap on the grid. So, so this is used in business and other areas to as a stakeholder engagement tool to help understand your stakeholders. And it's an axis. So along the bottom axis, we've got the interest of the stakeholders, and then up the other axis, we have the influence or the power of the stakeholders. And this can help with two or a number of things. So you can help us to categorize your stakeholders. So if they've got high interest and high level of influence or power, these are the key players. These are the people that you really want to engage in closely. Low power but high interest, keep them informed, show consideration. Low power, low interest, well, these are the least important. You can maybe choose to expend less effort on these stakeholders. And high power, low interest, going to meet their needs, keep them satisfied. If they become dissatisfied, then they can have an influence on the success of what you're doing. The other thing is, as we've been placing people on, or organisations on this chart in the previous episodes, we found actually, we're saying, well, they're currently low interest or low power, but we'd like them to be somewhere else. So it's quite helpful for identifying those dynamics and then thinking about how you move people on the graph. So Gandhi, patients and groups of patients.
Okay, so I think if we're talking about individual patients, I would say within the networks, which is what we're talking about, so engagement with the PCNs and that kind of stuff, I would say they probably have low interest, and individual patients, I would say, probably have low power, actually.
But I think so.
I think that we probably want them to have more interest is the flip side of it. So, because I think the more interest they have as individuals, that probably leads into the next one, which is the groups of patients. But yeah.
Absolutely. So we want them to have more interest, but individual patients they're probably always going to have fairly low power. Actually, I think it's when patients group together, or you are considering groups of patients that they have a higher power. So I think we'll pop them there. Now, this is one of the differences I think or see when I've begun to think about engaging with patients as a primary care network as opposed to a practice, because at practice level, actually, maybe we didn't give it enough thought, but it's largely been about engaging with individual patients, inviting them to the patient participation group and listening to individuals. We have at times thought about inviting groups, but when you invite a group in to or a representative of a group to talk at the practice level, you've always got this dilemma of, well, how many people in their group are members of this practice and how many members of the other practice, and is that going to confuse things? So it's largely focused on individual patients. Primary care networks, you're covering a whole community in a whole geography. So I think actually it does bring groups of patients more into play. You can start to think, well, if there's a church in the middle, or a faith centre in the middle of your primary care network geography, actually there's a good chance that most people that engage with that group are part of the primary care network because they're going to live in the area. So it brings them into play, so which opens up a lot more possibilities. So again, the groups, they're probably high power, I think, but they're probably currently low interest. But we probably want to
move them across
to here, actually.
And I definitely agree with that. So if you take, for example, the health inequalities challenge that many of us have, vaccinations would be a great example. So we have groups of patients, potentially they are less keen, for example, hesitant about vaccinations, but actually engaging with those groups, maybe you are more likely then to help them understand the pros and the cons of vaccinations and help them feel more informed to move them to a place where they feel that actually that hesitancy may be something different for them. And actually by being able to do that with the groups, and particularly the group leaders who have potentially more influence than we would have, that's where you then see change. And I think that's one of the key things to help move people to a different direction and things. So definitely agree that groups have potential to be really high power, high influence, pending the groups and your ability to engage effectively with them, which is what we're going to talk about.
I think they can be really valuable partners when you're trying to improve things, which is really different to the dynamic with the patients, because at practice level, you feel that the patients come, they tell you about what they're dissatisfied about, and you try and improve that. I mean, it's more complicated, than that, and you can try and do more with individual patients. But I think there's a whole new dynamic available to us when we're thinking about primary care networks. So what we're currently doing might not be what we actually currently want things to look like. And we're not perfect. Other people are probably going to be doing it a lot better than we are. So I think we're just going to be honest about what's currently happening in our primary care networks, and then use the framework to explore what could be better, I think. Gandhi, your logo is top on this slide. Do you want to go first and just say what, if anything, you've been able to do in terms of patient engagement over COVID?
So with patient level engagement, I think we've done a couple of things. So you talked about the logo. So our logo was actually created by one of our patients, and we ran a competition when we started off as a network to create the logo, and it was a community sourced one, won by one of our the children actually from our network, and a really nice interpretation that we've just tidied up with a little bit of professional artistry and stuff. So basically it is the same, it just looks a little bit smarter, that's all. So there's an element of trying to expand what the network is with the various different populations from there. We've worked with a variety of local groups. So we've got a support charity called Small Steps, Big Change that have done some work with the groups that we talked about. So new mums in particular, and particularly new mums of non-English speaking patients to understand their healthcare needs. We've engaged with the local parishes to provide some kind of befriending pastoral kind of support services, particularly for patients who are bereaved, and to try and develop. So we are trying to engage with different groups, and we come up with different routes for doing that. So working with community partners, that kind of stuff, to then find these groups. That's the key thing. Our social link workers have been an invaluable resource for a lot of this, finding different groups. And I think that's one of the key strengths networks particularly have, is you've got potentially dedicated role that can be really good at engaging with these options. And as most people probably figured out, social media is featured for me a bit in terms of different avenues and stuff. And even I will say it can be done far better than what I'm currently doing. But I think there's a variety of options, and we will talk about some of the hints and tips to help you do that in your network. But in terms of my network, so we've got a Twitter profile. We've also got a YouTube profile that we use. And I was planning to go down the route of a newsletter for patients, which we have done a few times, that practice disseminate for us. Probably something more to do there, to be honest, but as ever, the job takes over sometimes, doesn't it, Andy?
Yeah, there's so much to do. There were a few things just to pick up on what you said there. Yeah, I think the social prescribers are a really good resource for like mapping the local community and mapping we use these terms now like assets, don't we, and things like that. But we're really talking about the community groups and finding out where the patients are, so that you can connect with them and actually making those connections. I know we've been sending our social prescribers and other people out to various community engagement things that happen run by the council. Things happen in Bulwell Market every now and again, or at Top Valley Tesco, and they go out there and they can actually just have conversations about how people are finding the services, promote some of the primary care network services, but also listen, and then feed that back in. But we probably need to be more structured about that. Something you said that I thought was interesting, Andy, was I think you were talking about sort of faith groups around bereavement or something like that. That actually sounds really interesting. Is there can you elaborate on that at all? Or?
So it's been piloted by one of our practices initially, so that they've got some of the local parishes coming in to provide pastoral support for patients who have been recently bereaved. And there's no real criteria apart from just a recent bereavement. And they're just offering pastoral, so it's not counselling as such, it's just support. And we're trialing it. So as a network, we're helping to fund some of the stuff that they're doing. They're doing it within the practice. If it works as a positive scheme and want patients interested in, we're hoping that may expand. So it's finding that I think the groups and the support services around you that you can look at to either invest in or adapt or support to then deliver more care.
Yes, that's really great actually, because those patients who are bereaved who have access to that sort of pastoral support, and often it is from a faith group, but not always. Sometimes from other groups that are well organised and provide that kind of community support. I always think they're going to do a bit better, all of the things being equal, than people who like those supports. That's really exciting. I've not really thought or seen that anywhere else, so that's really good. Yeah.
What about yourself, Andy?
So I think it's been difficult during COVID because for most of that time, practice as patient participation groups, which might be the logical first place to start to look to connect with the local community, have for a large part not been operational, or it's been quite limited because it's been done electronically, which hasn't always suited your traditional members of patient participation groups. So I think it's been a challenge actually to engage with patients. We've only just started to do that. I'll come to that in a second. I think where we have been successful in engaging with the patients, it's been through our community engagement efforts, which are a little bit more mature than the direct patient engagement. So we have had to the local faith leaders, council leaders, leaders in education, and the charitable sector coming together along with service leaders from local nursing, physio, other kind of health sector things, and the local council and the police and fire as part of Bulwell and Top Valley Health Forum. And we've had 3 meetings of that now. We're meeting quarterly and bringing all of those stakeholders together. We have some working groups that we've spun out of that because we've been looking at population health data and collecting the impressions of those groups about the needs. And we're beginning to design some some interventions around those working groups, which are in the areas of child immunisation, healthy lifestyles, and mental health. So that's been quite successful, but I'm not sure we can hand on heart say that that's sort of direct patient engagement. That's been less mature. We a few weeks ago had the first meeting of our we're not quite sure what we'll call it, but we call it a patient engagement group, PEG. Okay, not PPG, but PEG. We had our first meeting a few weeks ago, and we weren't quite sure where to start. And other people might want to emulate this, they might not. We thought, well, we need to start somewhere. So what we'll do is we'll get whoever is the chair or perceived as a lead member of each of our 7 practices, patient participation groups, and the member of staff who coordinates the patient participation group in a room. And that's where we'll start the conversation. And we don't expect it to stop there. It's probably at primary care network level going to be about targeting, groups, faiths, charitable, and actually being more innovative about how we represent and communicate with people. We thought we'd start it there. And Gandhi, 1 patient came. And thank you very much for coming, that individual. You may be watching. That person contributed a lot. And we had a really good discussion with the people who run the PPGs at the practice and that patient. And the discussion was largely around the limitations of practice patient participation groups in terms of the demographics of the people that come. Can be an older tilt, can be a tilt to your more organised, affluent personalities within whatever within whatever population you're in, and so the representation is challenging, and the types of discussions that happen at those meetings. So we talked about that. So we had a really good talk about how to improve things going forwards, which might lead us on to our next slide.
Okay, so if we are looking at improving things, this is our kind of like, tips guide, and we've used this before in some of our earlier streams, which you're welcome to check out and stuff. So talk us through it, Andy.
Yeah, so this, again, I'm not quite sure where I got this from. I think it's from sort of business or engagement kind of areas. And it's a good sort of scheme for thinking about engagement, the who, why, what, where, when, who. So think about who you're engaging with, that why, that's kind of the types of messages that you want to get to or from them. And then the what, sort of how what medium is it, written, video, etc. And then where, that's more thinking about the platforms or the physical spaces where it's going to happen. And then sort of when, how often, what's the framework around the communication. And then, who's going to actually do it? Is it all the clinical director or are other people going to do it? So that's the framework, really. Let's just talk through. So, Gandhi, in terms of who, how would you break down the who of patient engagement? Is it just patients, or can we be more?
So I think we've already kind of covered this. You would like to have a system that goes to all patients and broadcasts information for them to be engaged with, but the reality is that their engagement with it is going to be fairly low, generally speaking, unless you come out with something really controversial. It's more those groups, leaders of the patient groups kind of things that you probably want to target and engage with, because they're the ones that will hopefully support the work that you're looking at doing, but also you'll be able to target it more towards their group needs, which is actually what we're trying to do. In particular, when we keep talking about health inequality as being part of this. Those are the real groups, and many networks probably want to engage with quite significantly because they're the ones of most potential need. So, understanding who those leaders are and how to engage with them is probably the priority.
Yeah, I think you can be a little bit more ambitious with the who at primary care network level compared to practice level.
Yeah,
and you might actually need to engage with a few different who's. I think, because I think there is something about the engagement with the individuals, and that might be more of a broadcast, mailing list, Twitter feed. But I think people can receive and engage with information at a personal level. But then I think you also need to sort of build out some apparatus for engaging with the groups, because I think that's how you can kind of amplify the reach, because those have channels of reaching individuals, potentially people who might be harder to reach. For example, we've had some conversations with people who run the homelessness services for the council, for example, and actually they have special places and reach and trusted relationships with those people. So there's something about actually engaging with groups of people as well, and the channels and what you're trying to achieve might be different, I guess. So really a good consideration of the who, I think, is helpful. And then just thinking about the why, I think this is different to practices in a way. I think it's a bit more expansive. You can be a little bit more ambitious. We've got a list there, but have you got any specific thoughts about the why, or what we're trying to achieve with the communication?
I think it's like you said, it's just not being restricted to practice boundaries, because that's the thing. Practice will aim to try and engage with their patients, their practice patients. Networks aren't constrained by the same level of grouping in the same sense, because the network can actually be wider than the practice boundary, the network boundary, because actually, particularly when you're looking at services across large footprints like ICPs and stuff, which actually the networks obviously clearly sit within, you will have to sometimes work across boundaries. It could be council boundaries, could be local authority boundaries, all those different kind of things. So actually you have to engage much wider than the footprint of your actual practice populations, and I think that's why it's a different perspective, as you said.
It is. And I just to break it down for those listening who can't see the slide, I mean, I think traditionally with patient groups in practices, we're getting feedback about services, aren't we? And often people are there to to give us that sort of negative feedback that they think that we need to hear, and that's important that we hear that. So I think that's part of it, but there's more to it than that at primary care network level. I think there's something about making people aware of services. Primary care networks themselves are offering quite a varied sort of range of services, and there's a need for people to understand that so they can engage properly with it. Practices often will try and get messages out about health understanding, around maybe vaccines, around signposting to services, about screening uptake, about influencing healthy behaviours, preventative measures, medicine, positive change. But it's a real challenge at practice level. And there is something to be said, I think, for trying to do that more at primary care network level, and there might be more success in doing that. So I think that's part of it. Also, increasingly, as we've got our working groups and we're thinking about potentially formulating bids for some new funded services or rolling things out, there's a need to engage with patients about service design. It's all fine designing something that the clinicians think patients will use, but we may find they don't actually want what we think they want. So you need an apparatus for engaging with the right patients about the service design, which is good. And then the other thing which we begin to think about, because we've got interest from local MPs and councillors, I think actually we could campaign for better resources for this area. So actually, once you've got a group of people together, there might actually be quite a powerful lobbying group if you construct that in the right way. So those are the sorts of whys that we'd thought about and popped on the slide.
Okay. In terms of the what, so these are kind of your modes of communication. I think there's a variety of different options. There's obviously written word, and that could be electronic or physical. Whether that's emails, newsletters, that kind of stuff, or whether it's blog posts, or whether it's posters, those kind of things. Audio, we're big fans of audio, but even that's expanding as time goes on. There's the podcast as an audio kind of broadcast. But now we've also got newer formats, things like the Clubhouse Twitter space kind of thing. That's expanding a little bit. Video, massive fans of that, YouTube in particular. But don't forget other routes like social networks and stuff. And then in particular, the in-person.
Yeah, let's not forget.
Yeah,
it's probably coming back. And there's in-person physical, and then there's still something for the Zoom meeting or the team meeting as well, which is not in person. But it's not a broadcast media, it's a real-time conversation. So I think that's different. Something that's just occurred to me that is part of what we're trying to do, or what my vision really is for the primary care network communication. And it's not to necessarily think that the PEG, the patient engagement group, is the only place where patient engagement happens. And so I'm really keen to sort of make it a bit more broad and kind of part of everything that happens, so that actually we've got working groups, we've got a health forum, we've got lots of other places where a patient voice might be valuable, and to try and actually bring them to all of those places, rather than take the working group to do a presentation at the PEG, for example. So to try and just make it part of the DNA of the primary care network to engage in that way. Talk about where. So this is where you're particularly knowledgeable about all the different platforms, particularly around social media. But we were beginning to think about where you might want to get those messages out. And we'd done a few. So do you want to do a few, but leave some for me as well?
Okay, so I think in terms of where the big ones that most people will probably think about are going to be the big social media networks. So things like Twitter and Facebook, they're big ones. As you mentioned, Andy, it's important to remember that the types of populations that will look at. So, Twitter is broadcast. It's good, but it's not going to be necessarily where everybody wants to be. If you're looking for local communities, Facebook is probably better at that. But important to remember that the majority of people that use Facebook are your 40, 50 pluses. If you want lower age groups, Facebook is not where you need to be. You need to be on things like TikTok and Instagram and that kind of stuff. And that's much harder media for most practices and PCN potentially to engage with, because it's newer kind of media. It requires content creation, it requires a lot of engagement to build on that kind of elements and things. I'm going to cover a couple more, but I'll let you jump in with the ones that you wanted.
Well, I was just going to talk more about the kind of the physical side of things, because there's a physical where, isn't it? There are electronic platforms, but there's like real life platforms. That like getting into practices, waiting rooms. Some of our before the COVID times hit. Some of our patients from our patient participation group they made their own survey, and they just chatted to patients in our waiting room, and got information from them. There's the physical places where patients go, like to supermarkets, to the market. Actually moving to them where they are physically helps. And there's also, the groups, the spaces where people are, faith spaces, interest groups, actually going to those places. The guy from Health Watch was talking to me the other day. I think he's called Richard in the area. And he said, really, if you want meaningful patient engagement, you've got to go to the places where patients are to talk to them. And in a way, I thought that makes a lot of sense. My heart also sank because I thought about the resource implications of trying to do engagement in that way. Wouldn't it be so much easier if they just came to us, which is the traditional model? But so I just wanted to give a shout out to the physical spaces, and maybe also legacy media as well, because we've been beginning to have some conversations around expanding the reach of our vaccination program with local councillors and also local kind of sort of ethnic group representation.
Absolutely.
And there are certain radio stations, news outlets, in Nottingham, like Dawn FM and Kemet FM, for example.
Kemet FM. So big shout out to them. I've been on them a few times with Lucy, our local public health consultant, and talking just about that whole concept of vaccination use and hesitancy, how patients can understand that. And you're right, it's a real good way to engage with particular communities because it's their trusted resource and stuff.
So I just want to give a shout out to those. Sure. And the final one is physical websites as well. I'm always surprised how much traffic our practice website gets. So actually practice websites, if you can create information that practices can easily put on their websites about primary care network services, as a pack or videos that they can embed and make sure they know how to do that, they actually get quite a lot of eyeballs on practice websites. And there's also something to be considered about having a primary care network website. And that might not be because you expect loads of people to navigate there, but it's actually a good place, I'm finding, to embed say videos or pages with some information and links about vaccinations that then you can direct practices to, or you can direct patients to. When you send them a text message about their COVID vaccination, you can have a link to a page where there's a video embedded showing them what to expect when they go for the vaccination. So just a shout out for websites. There you go.
It's that concept of centralized versus disseminated, isn't it? And the practices are probably better at doing that for you, but in order to do that, they need the resources, which actually need to host that somewhere, which is why the network website works. The other two ones I'm going to quickly mention, Google Business. So I'm a big fan of this for practices. For networks, it only really works so you have to have a physical premises, first of all. So it's not going to be every network, but it is that option of understanding and expanding kind of the resource that you've got. And the other one is LinkedIn. Now, LinkedIn's a very specific use, I think, for networks. It's in recruitment. Okay. So very much for network. It's not going to be for patient engagement, but important to remember that some, if not a lot of your workforce is going to be people within your geographical area, which are likely to be patients. So there is that element of, if you're looking for workforce, particularly things like the care coordinator roles, the social link worker roles, then the non-clinical ones, because to be honest, most clinical staff will probably look at NHS jobs and that kind of stuff. But the non-clinical roles and the engagement with those, actually, LinkedIn, really powerful resource.
Again, just a slight segue around recruitment. This is something that it's taken me a while to get my head around, because traditionally when you're recruiting as a practice, you don't want your own patients to apply for staff because it's complicated, because they'd have to then choose to leave the practice as a patient and work somewhere else. So kind of my mindset was in a place of avoiding recruiting your own patients. But actually some of the better, everyone's good who works at primary care network, but some people, if you want people who really understand your community and your
need to be from the community.
Patients, it really helps if they're from the community. So I've just had to realize that I had that slight unconscious bias about recruiting from outside the area for some reason. And actually people within the community can be really, really great assets for the primary care network. I just wanted to add that, Gandhi.
So next we're going to talk about the when. So just a couple of my personal tips in terms of things you can use. Automation software to help you do some of the social media kind of things. So I'm a big fan of a platform called Publer. I know you use Buffer. Use something to help automate the process. If you want a little bit more depth into that, things like Zapier or If This Then That. My personal tip that I use, so I've set up Zapier links from my practices that automatically copies over the tweets and the messages they put on their social media platforms to their network-based one. So there's some building content. It's not great. It's much better if you do it your own one and copying and the assets, reusing and stuff. But it's a nice little way to build some regular engagement and stuff.
Yeah, I think those are really great tips. And how often? I mean, that depends on what you're doing and the media, doesn't it? I mean, a physical meeting that's quite ambitious and pulls a lot of people together, it might be appropriate to do that quarterly, But in terms of social media presence, if you did that quarterly, then you're just going to be dead, aren't you?
It needs to be a lot more frequent, and feel free to check out some of our videos that talk about the use of social media to engage with populations and stuff. That gives much more detail about individual platforms and stuff. The who.
Yeah, so this could read how if you do the letters around. There's a big question about who's going to do it, because we're now talking about quite a complicated kind of engagement apparatus operating at a fairly big scale, covering 50,000 or so patients. So I think you can't just say people are going to do this in their spare, unstructured time, or the clinical director is going to do everything. I think you have to be very deliberate about allocating resources and staff time to doing it. Many of us have a network manager. We're currently filling that post now. I can't wait for our network manager to start. But we're also going to position someone as a comms lead for a few hours a week as well, to stay on top of patient engagement and these engagement channels.
And that's something to explore as well. So, your CCGs will have comms leads. Your federations may have comms leads. Actually, rather than you going off and having to create your own one for your own footprint, could you lean on other services to say, actually, can you help support us with this? We can potentially finance some of it. And if you did, a few hours a week, potentially that's, LMCs, possibly great resource for some of this, because actually they could do it for multiple networks in one go, similar to federations or CCGs or there's opportunities there.
It's interesting because we recognise that, but I often find a little bit of friction in getting people to do this sort of work for the primary care network. I don't know what your experiences have been, but people are often, they have the job from that organisation, and it can be difficult to get them to engage how you want. They often come with some perceptions about what they're allowed to do or not to do. I don't know. It's interesting.
I think that's probably the difference between asking them to do it as part of their existing role compared to potentially looking at outsourcing it as an additional role. Yeah. Maybe there's something there.
I think that's fine. Although sometimes, somewhere they're commissioned to actually support you with this, but you find there's still friction.
Exactly. Absolutely.
So, and then the other thing I was going to say was there's something about the process of it. And what I'm keen, and maybe this is ambitious, is actually to embed the patient engagement within some of the everyday processes that happen. So, so I've put maybe everyone should be part of this, because what I would really like is, after we've had a leads meeting, that actually we're maybe capturing some comms needs as action points from that leads meeting, and actually after that, the network manager or the comms lead might immediately fire off some tweets, and so forth. So it's embedded in the process, or that our social prescribers, when they learn about a new service, that they actually feel empowered to just tweet about it or TikTok about it straight away. I'd like to make it just part of what everyone does.
I mean, one of my plans for the YouTube one that we're doing is showcasing what the different ARS roles can do for patients, that then that resource can be used by practices to share with patients from their own practice when they're looking at, okay, you're not sure what social link worker could do. Here's a case example of the social link worker talking about what they have done for other patients and why this may be a really useful service for you. Similarly, I mean, most clinicians don't know what half of these roles do. We need to educate not only the patients, but the practice teams about this. And we're going to cover that in our next episode as well. So.
And actually, you're right. And actually, if you're smart, some of the messages that you need to get out to the other partners, like the other NHS partners and the other community group partners, and your other staff at the practices, are the same messages you need to get to your patients. So if you actually pitch the information level at the right level, you can actually, I think, make it relevant to all of those people and save yourself duplicating effort.
Absolutely. So, Andy, we've talked about the way to kind of do it and everything. What's next? Well, I think if this is something you're interested in, definitely recommend that you give it a go. We've kind of shared what we've been trying to do. I think I'd love to borrow some of your ideas about the community engagement side of it. I think engaging with different groups is a real powerful thing. And I know that's something we've started to do. You're probably about 6 months ahead of us in terms of that journey. And what's next for you?
What's next for us? we have a second meeting of the PEG planned. We've actually got quite a lot to do in between then in terms of trying to reach out to various groups in the community. So I think it's that group outreach to then bring people into the conversation about patient engagement. And I think that's for the two-way dialogue with groups. And then we just need to kind of complete the build out and use of our website and social media channels, which I think is where we can learn a lot from you on social media and get that kind of that broadcast element embedded within what we're doing day to day in the primary care network. Looking forward to it.
Absolutely. So we would love to know from you what you're planning on doing. How are you going to look at engaging with your network population? What are you already doing that enables that to work in some ways? And what is it you would love to know how to do better, differently, or other ways? Yeah, we'd love to hear that, wouldn't we, Andy?
That'd be fantastic. And other people can see when you comment as well. They might have the answer if we don't have the answer.
So as always, comments down below, whichever platform you're consuming this on. As always, we're here to try and help in any way we can. We're going to have some more videos coming up in a second that will take you to other kind of things, particularly our earlier episodes and our next one once we've recorded it. And as always, EGP Learning is here to help tech enhance your primary care and learning. We'll catch you in the next episode and next year as well. Catch you later, everyone.
Bye-bye. Do you need to pick your